The abortive treatment. In the production of chronic urethritis, the abortive treatment has taken the place of the sound of our forefathers. In exceptional cases, it is possible to abort gonorrhea. Indeed, in some cases, gonorrhea almost aborts itself. But it is almost impossible to abort a first gonorrhea, and often impossible to abort subsequent attacks. After experimenting with every method of aborting gonorrhea I ever heard of, it is my present conviction that the surest way to abort gonorrhea is not to try to abort it. The repressive treatment every now and then results in a rapid cure. Last winter, I had the pleasure in a single week of curing 3 cases of acute true gonorrhea, 2 of them within 7 and a third within 12 days of its inception. But I treated no 2 of them alike. They were all secondary gonorrheas. I made no attempt to abort any of them, and in the 6 months since that time, I have cured but 1 case within 4 weeks. Footnote. This paragraph was written in 1910. My conviction remains unshaken today. Bierhoff reviews the opinions of various authorities and claims 50% cure for the following modification of the method of Frank and Lewin, who report 45% cures. A microscopical examination of the secretion was first made. If the discharge was slight, and if the majority of the gonococci still were extracellular, then the Protogol solution was employed in the strength of 1 to 6 to 1 to 3%. If the discharge was at all pronounced, or if the greater part of the gonococci were intracellular, then a 1 to 3 to 1 to 2% solution was used. The method was employed naturally only in those cases in which the second urine was clear. After urination, the urethra was anesthetized by an injection of a mixture of 4 cc's of a 1% cocaine solution and 4 cc's of a 1% Protogol solution. After this, the anterior urethra was cleansed with 150 cc's of the Protogol solution. Following this, an irrigation of the whole urethra was made, according to Janet's method, with 150 cc's of the solution. The patient then emptied his bladder of the irrigated fluid. This irrigation of the entire urethra with immediate emptying of the fluid was repeated from 1 to 3 times in the same sitting, so that the urethra was flushed 4 to 8 times. In addition, the patient was given a solution of Protogol, 0.5%, with which he was instructed to inject 3 to 5 times during the day and to retain the fluid 10 minutes each time. During the succeeding days, if the gonococci had disappeared, the strength of the solution and the quantity of fluid injected were diminished to be suspended if the result was positive on the 4th or 5th day at the latest. The injections by the patient were also diminished and suspended in a similar manner. Then followed the usual provocative test and control examinations. Kreisel employs the following treatment for every case of acute urethritis of less than 2 days duration. After irrigating the anterior urethra with a hot boric acid solution, a constricting rubber band should be placed around the penis at the penoscrotal junction, and 1 dram of a 4% Protogol solution injected and retained for 5 minutes. For irrigation with the boric acid solution, a piston syringe and a sterile elastic catheter should be used. No pressure to distend the urethra should be applied, and the fluid should commence flowing through the catheter before it enters the urethra, whereby the dissemination of infectious material is avoided. During the following 8 days, the anterior urethra should be irrigated in the same manner with a pint of a 1 to 3,000 hot nitrate of silver solution once a day. The discharge, if there be any, is examined microscopically every day. If no gonococcus be present in the last 5 specimens, the treatment may then be discontinued. Otherwise, the systematic treatment for gonorrheal urethritis should be commenced. Excellent results are also attributed to permanganate employed in the routine way as described below.